Public Health Agency and the Chief Executive, Dr. Eddie Rooney, and colleague. And again, what I'll ask you to do, Eddie, if you'd introduce yourself, your colleague, and your roles, and then we'll have a short statement and then follow that by questions. So the floor is yours.
Thank you very much, Chair. I'm Eddie Rooney, Chief Executive of the Public Health Agency. I'm joined by Pat Cullen, Director of Nursing and Allied Health Professions, who you met last week as well. If we can just start by saying that the fundamental role of the Public Health Agency under the 2009 Health and Social Care Act includes protecting the community, improving health and social well-being, and reducing health inequalities. Key to our function, and a quote from the legislation, is enabling people to increase control over and improve their health and social well-being. And absolutely central to that is to ensure that people have a strong and a genuine voice that is both listened to and acted upon. Thanks to the dedication and professionalism of staff within Health and Social Care, Northern Ireland does have a strong focus on quality and safety to improve the patient experience, but we are never complacent, and continually we're looking to adopt best practice, to drive innovation, and most importantly to learn from and improve when we do not meet the highest standards. These factors are reflected in Quality 2020, the Department's overarching strategy, but they also filter down into the more detailed work undertaken by the Public Health Agency to improve the patient experience. Our focus is on preventing ill health and premature death, and we do this working in collaboration with others at all levels of our society. This ranges from our work right at the heart of health services and quality and safety, but also in the heart of our local communities to tackle, for example, the social determinants of health, such as education and poverty. Our starting point is that although the overall trends in life expectancy and quality of life are positive, things are not all right for everyone. A significant part of pain and suffering and death in our community is avoidable, and we know that this burden is not evenly borne across our society. We also know that addressing the causes of preventable ill health and death cannot possibly be achieved by the Public Health Agency acting alone, or indeed the health sector on its own. So our legislation is explicit in requiring us to cooperate with other bodies to improve health. Our role is not restricted to specialised areas of public health. Our statutory role includes informing, advising and assisting the Health and Social Care Board, local commissioning groups and the Department in their duties, and we have an explicit approval role over the whole Health and Social Care Commissioning Plan before it can be published. This is just to set the scene regarding the factors that drive PHA work in relation to patient safety generally and the specific areas you've highlighted for discussion today. In practical terms, our role is to uncover the true story, seek out the factors that contribute to poor health, and work with all our colleagues, whether in health and social care family or in the community, to help in any way that we can to improve health. We do not simply gather data, we analyse it, and we help to ensure that it is applied to improve health. We always aim to delve below the surface. We know, for example, that surveys, for example, the Newry survey in health, showed high levels of patient satisfaction with our A&E experiences. And even our own work in 10,000 Voices, by far the majority of stories gathered are positive. But we also know that the most important lessons for improving health could lie within those smaller amounts. So we do dig deep in the analysis. We add the experience of frontline practice to try to find the factors that may be of greatest significance. We do this in cooperation with others, which is well illustrated through the partnership approach we've used in 10,000 Voices. In this, patients and staff from all disciplines, including porters, domestics, administrative and clinical staff, work together to address issues and implement quality improvement plans to enhance the patient experience. And while the PHA is not the performance manager of the health system, we do support those who are. The Department has given us specific responsibilities in relation to monitoring and reporting on the patient-client experience standards to ensure that best practices embedded across the health and social care system. I know you've identified 10,000 Voices, one issue that you'll probably want to explore later on in the discussion. I believe it is a good example of how our approach can work. Last week we launched Hello, My Name Is, a fundamental step to encourage staff to take time to introduce themselves. A simple but important initiative which was a direct result from the patient-client experience standards work, and specifically from 10,000 Voices. And many more improvements will follow as a result of the influences on patient experience. Actions such as this are small steps in what needs to be a cultural shift that embraces all health and social care. While that is a long journey, I'm optimistic that the commitment which we are seeing now will have an early positive impact on the patient experience. We appreciate how high the stakes are for patients. Those who work in the health sector and our families and our friends are users of the services we provide. In that context, one bad experience is one too many. In general, health and social care provides a high quality service, but this is not about generalising. Each and every experience that patients have is important to us. That's why we're focusing on using the patient experience to lead to quality improvements. We very much welcome the opportunity to participate in the inquiry and are very happy to take questions.
Eddie, thank you. I want to kick off, and it's really building on the comments you made about you look at the data and dig very deep to below the surface to make sure that the lessons add to the experience alongside with what you pick up from feedback from frontline practice. And what I'm interested in is the role and the relationship of the agency and the board. And the same data goes to the board as yourselves, as I understand it. So I wonder if you can take me through and perhaps give me some examples of how you feed through your views to the board. So when you've done that digging deeper and you're coming to some conclusions, you're seeing issues, how do you make sure that that the board is aware of what those conclusions are? And then what role do you have, for example, when the board commissions services, so that you make sure that the board is taking on board, pardon the puns, the lessons that you have got from the data? If you could talk us through that process, but with a couple of examples of where it's worked, and maybe a couple of examples if it's appropriate, or perhaps where it hasn't worked.
If I can get Pat to take you through the first bit of that, and that's a process which will illustrate that, and I'll pick up the second bit then in relation to commissioning and how we actually go on to make it happen.
Yes, sure.
Okay, well, as the Director of Nursing within the Public Health Agency, I'm employed with the Public Health Agency, but also embedded within the Health and Social Care Board as their Director of Nursing. So, in a sense, I work across both organisations, providing professional advice to the board whilst employed by the Public Health Agency. As Eddie has said, the responsibility of the agency is to ensure the implementation of the patient and client experience standards, the departmental 5 standards. It's also my responsibility to ensure that those standards are brought to the Health and Social Care Board table, and that the responsibility for monitoring and the arrangements we've got on monitoring is reported on a very regular basis at both tables, through to their senior management teams, and then through to both boards, both the Health and Social Care Board and to the Public Health Agency Board, and that happens on a very regular basis, and I'll tell you a bit about that. In terms of how we do that, to take forward the 5 standards, we have a range of methodologies in place. You'll have heard throughout the trust evidence that we gather patient stories, which includes the 10,000 voices, and I was the architect of 10,000 voices, and I'm very proud of that. We also carry out observations of practice. So in every department that we monitor the implementation of the standards, we carry out actual observations of practice within those areas. We issue questionnaires. We then look at the information that we get back in relation to those 3 methodologies and compare and contrast the information that we get from our complaints. And we also look then across at what our serious adverse incidents are telling us. So I have arrangements in place for analysis of all of that data, and for it all to be brought together and used then to really drive improvements across. The information, as I say, is analysed on a regional basis as well as locally by each trust. The trust then feed it back to us, and then it's our responsibility to identify the themes and trends from the analysis that we get back from the 5 trusts. And of course then take an account of what patients are telling us through the 10,000 voices. We do that on a very regular basis. We look at the 10,000 voices information on a weekly basis within the Public Health Agency. And we do that because it's really important that when patients tell us things that we act immediately, and that's the beauty of 10,000 voices, that we have the actual information, patients feed it through to us, and on a very timely manner we are able to work with trusts to make change and act upon the things that patients tell us. So then the Public Health Agency, working across with the Health and Social Care Board, will identify what regional actions we intend to put in place, and then we put implementation plans, regional implementation plans in place. And we've seen a good example of how that happened last week with the regional launch of Hello, My Name Is. So that's really important to us. Then in terms of complaints, we review all complaints on a monthly basis with the Health and Social Care Board. We look at the key issues that are coming out of that, and then we link it back with our patient and client experience standards. On a bi-monthly basis, I take reports both to the Health and Social Care Board senior management team and to the Public Health Agency team, and then twice a year quite comprehensive reports are brought to both boards as well, and the actions and the recommendations and the action plans are brought to both the Health and Social Care Board and to the PHA Board. Now, underpinning all of that, we have a regional steering group, which is chaired by myself and co-chaired by the Director of Finance within the board. So again, that's the partnership working right across both, that it's not seen as something that belongs to one organisation and the responsibility of one organisation, but it belongs to both. And it's not just the responsibility of a nurse, but it's the responsibility of everybody that sits at that corporate table. So we have a regional steering group which comprises all of the directors of nursing and those directors that have actual responsibility for ensuring the implementation of the standards across the 5 trusts. RQIA also is a member of that group, and also the patient and client.
Can I stop you there? Those processes are clearly very important. What I want, I suppose, to drill down to is, and you gave one example, which was the hello, what my name is. Can you give me a few examples of where you've taken the data that you've got and are now seeing you've used that, fed that into the system, and know here are some examples of things that we've implemented as a result of those processes.
Yeah.
I want to kind of get to the practical realisation of all those processes.
Plenty of those, yeah.
Yes.
Okay. In relation to privacy and dignity, patients within the emergency departments were telling us through 10,000 voices and the feedback from the implementation of the standards that the things that were important to them, what they're really saying to us is the care is good, care is excellent when the care is given, but it's the experience within the emergency departments, and patients are clearly telling us that through the stories. And the issues that are continually coming up through the stories was that they are cold within our emergency departments. They would like to have access to pillows and blankets. And particularly our elderly patients are saying, because, as we've heard from RQIA, they have long waits within emergency departments to be admitted to a ward, that there's very limited access to beverages and to food. So as a result of that, I brought those issues to the Health and Social Care Board, and funding was made available to put in place processes where pillows and blankets, simple things, are available on a continual basis within our emergency departments. It might sound simple to do, but when you have patients on trolleys and patients in beds, pillows and blankets go very easily, so we do have to replenish that. So we have processes in place now for that to happen on a continuous basis. We also now have identified within the emergency departments an individual or individuals that are responsible for ensuring that people have access to food and to water. And that's really important because that wasn't happening. So we have identified people, though that's fed back in the action plans, and we continually monitor that. And again, that was support from the Health and Social Care Board to make that happen. So those are just 2 simple but very, very important examples to people.
Maybe, Chair, if I can just add in terms of the second part of the question, from a system point of view, I mean, if I can paraphrase you, how are we making sure we're having enough clout in the system, having enough impact? In that relationship between Health and Social Care Board, as we build the commissioning process, the requirement is to take due regard of the advice that the PHA provides through our professional advisors, and that impacts on all aspects of commissioning. Our board then has got to assess and make sure that we're content that due regard has been taken before we approve the overall commissioning plan. So the detail that Pat is talking about filters its way into a commissioning plan that will be ultimately passed jointly to the department, and that goes through the PHA's processes and governance processes as well.
Okay, and in your view, does that work well? Is it taken seriously and properly? Yeah. Is your voice heard then in commissioning? Do you see in the commissioning decisions the kind of evidence that suggests, yes, our input really is in that commissioning
Yeah.
role and in that commissioning plan and what is being asked of trusts?
Yeah, absolutely. And I say, as the years have gone on, our own inquisition of ourselves in terms of that has got stronger and stronger each year. So I'm very content. And we do have to say, I give Pat and our colleagues quite a grilling before we sign it off as well.
Okay. I'm going to pass you to Marion, who will interrogate you a bit further around the issue of 10,000 voices.
Eddie's used to me interrogating.
Indeed, Marion.
I have a question which is in 3 parts on the 10,000 Voices project. And the first one is, are there any key messages that emerge from that project which relate specifically to emergency departments? The second part is, will the 10,000 project be ongoing? And if not, should it be? And the third one is, what other approaches do you have which augment the information you would be getting from the 10,000 Voices project?
Yeah, I'm going to let Pat do 1 and 3 and I'll do 2.
Okay. The key issues, Marion, that are arising out of 10,000 Voices for the emergency departments, patients are telling us that they are very frustrated with having to wait so long. But in fact, when you start to read into the stories, and there's some very powerful stories, and patients are telling us a lot of detail, it's not so much about the wait, but the actual communication throughout that wait, not knowing what's going to happen to them next. So left sitting, told someone will come back to them, and then because of the busyness of the department, that can be hours later. And then relatives and patients are telling us in their stories that that's a very fearful time for them, that because they don't know what's happening. So again, that was a key issue that we've picked up with the trusts and are working on in terms of communication. And now we see within emergency departments, all our emergency departments have now got signs up indicating the length of wait and what patients should do if they feel that they need to speak to someone throughout that wait. In fact, then we've gone further than that, and professionals are going back on a regular basis to inform patients about where they are in the system and what's happening to them. So we're trying to close that loop as well. It's not perfect, but it's a continuous monitoring process to ensure that that happens. So it's the communication. The other issue that continually comes up is around the lack of information and involvement of relatives. So relatives feel that they are not engaged in the way that they would like to be. And again, there's a number of reasons when we speak with staff. There's a number of reasons for that. Our emergency departments are not designed for the number of people that are coming through, so sometimes it's difficult and challenging to accommodate relatives. However, again, working with our emergency departments are putting arrangements in place to ensure that the key relative or carer that's with an individual arriving at the department is constantly advised and informed and kept up to date. The other one that came out in almost every story was our emergency departments being very, very cold. And again, that's back to now having a continuous flow of blankets and pillows for patients. Again, food and drink, particularly for our elderly people, and emergency departments are not designed for being able to bring food and drink in because it's difficult. Patients were saying, and again, listening to our staff, it's difficult to balance trays on trolleys, and we have to look at ways that we can bring in a safe way food and drink for our patients whilst they're in emergency departments. But we've managed to do that, and indeed some of our departments now have a regular trolley that will go round with food and drink, and a member of staff's allocated to ensure that that happens on a regular basis. So those are some of the key improvements that have come out of both the 10,000 Voices and looking at the patient and client experience standards and their implementation.
Yeah. Marion, if I can pick up where to go with it from now. I mean, you will appreciate my background as research and spent a lot of years in that. And every now and again, an idea comes along that just, I don't know whether it hits the right time or the way it's implemented, to give credit to all the people, but it just sparks and it really does get us animated. I think 10,000 Voices is one of those. I'm no stranger to qualitative information, but it really seems to have hit the right time as we've been developing personal and public involvement, Quality 2020, all these different strands from the clinical excellence, all going roughly to the same direction, but this big link of actually it's not even getting the patient's stories, it's getting them in a rapid turnaround and a rapid entry into the actual processes, not only in terms of central government and indeed the implementation bodies, but particularly the trusts in the front line. And it has really, I think it's really sparked imagination as well from the researchers in terms of being a new approach. We're heading really at the end of a first phase of it, and I'm pernickety. I mean, I'm very interested in squeezing as much out of the methodology side of the analytical side and learning as much as possible. But we are looking to phase 2 now, very much. But it really does look like it is going to be one of those potential game changers.
Thank you.
Okay, I shall pass in at Paul.
Thanks very much for your comments and remarks, and I'd really appreciate your advice on a couple of points. We're hearing from some quarters, but not all by any means, that the National Health Service in the region is, or maybe has been, a bit top-down. Now, a human rights-based approach to health, of course, favours, so far as possible, a sort of bottom-up participatory approach. So far as possible, one has to be realistic about it. And that's participation so far as possible by professionals, patients, and the public. And clearly, the 10,000 Voices project plays a really important and really commendable role, it seems to me, in contributing to a bottom-up process. And there are other mechanisms as well. So please don't interpret my question as being a hostile question. I'm just interested to know, in your view, as to whether or not it would be helpful, is it needed to further enhance public participation in the formal structures of the trusts and the board. And behind my question is not the conviction that there should be. I'm really interested to know your view about that, because my mind isn't settled yet on this. So do you think this is something that one should endeavour to improve, the sort of perhaps more formal participation? Let's focus on the public, formal participation of the public in trusts and in the board, or is it pretty participatory, public participation? Is it pretty good already? I'm really interested in your view.
Yeah, well, I mean, you've asked me for my views, and I'll take the views quite broadly from wider experience. I mean, I've come into the health sector just in the last 6 years from central government, and I've worked in 6 government departments in that role, so I've seen a lot of what has happened, particularly over the last 15 years, in terms of attempts to engage the public. I don't think there's any doubt. It is top-down. I think all of government tends to be top-down. There have been huge developments, I do think, in terms of an understanding of the value of engagement has really taken root. We're at a very early stage of putting that into practice, but there are some absolutely brilliant examples. 10,000 Voices is one, but that has actually been built into some of the day-to-day work, and we're doing work in allied health professionals in relation to special education needs, and immediately it's a direct involvement and engagement with the children, and the parents and carers is taken into the design. Now, a few years ago, people would have been puzzled how you did that. So we're now getting more practice, and I think those general fears about how do you handle this input from the public, as we're getting better practice at it, we're getting better at the methods of it. In terms of the structures, what I would say to you is a balance between the involvement in structures, which is only one part of it. It's much more important to get the actual involvement in the processes. and certainly the approaches that I would have been involved in have been about whole system approaches in terms of policy, from policy formulation right through to engagement. And that really is part of that cultural shift. You know, very important to have all aspects of society represented, underrepresented aspects and the formal structures. I do think that the power comes in actually freeing up that potential in the shaping and the design of the policies and strategies and practices. And doing that with the right heart will make the difference. Internationally, we've now got literally thousands of examples of how to do that and do that very efficiently and do that effectively. What everybody is finding is it leads to better policy and strategy, and actually quicker and more effective policy and strategy. So the methods are there. I think that the health sector, as many other sectors, been slow to get that off the ground. I think the momentum is genuinely there, but we have to say, I'm not going to over-egg it. We have a long way to go in this, but I do think that basic core understanding and commitment is actually there now, and I think the door is really open to push on this.
And do you have any suggestions, guidance on what the next steps might be to continue this, really commendable improvement in public participation in the health system and ED in particular? I mean, there are the service users groups, aren't there? And there's 10,000 Voices and so forth and so on. But I'm just wondering if, given all your, collectively you have enormous experience, whether you sort of foresee a good next step to take in order to keep this going.
I think that the example of 10,000 Voices, I think, is very important in pointing to that direction. Certainly in the past, one of the biggest frustrations that I've had where I've involved and engaged people from outside is they've never ever seen the results of the inputs that they've made. Somewhere they've either got buried in the system or just disappeared to it. Where you've got a system where you can actually, it is responsive, rapid, and very, very transparent, and you can see the impact that your voice has made, to me is the key. And I do think we've made a fantastic start in 10,000 Voices. When I say I'm pernickety from squeezing as much benefit from that, I think refining that and spreading that through the system, because even at the moment we've actually encouraged a bit of diversity for people to try to figure out how to do this in their own organisations and make it happen. Now we've got to move to a much more consistent approach and to spread that. But I do think we've got a fantastic basis to do that, and we know how to do it now.
Is one very small step in the right direction to ensure the 10,000 Voices project continues on looking at unscheduled care on an ongoing basis? If I understand correctly, forgive me if I've got it wrong, it's not sort of permanent in relation to unscheduled care. So is that something that, is that a step in the right direction?
Yeah, Pat will tell you the detailed plans for that. Yeah. For me, I think it's absolutely important that we do not see a process that seems to dip in and then out and leave, almost tick the box, done. I mean, this has to be an ongoing engagement process. That's its power. So, my view is, we should never leave the areas that we have gone to, but I think you've actually built that into the plans.
Yeah, we have given a commitment that it will continue, but we do have to allow for a period of for people to be able to put improvements in place, because it can't be seen as just continually gathering information, but not allowing people a bit of time out to actually take time to embed improvements and for us to work with them to do that, because that's our job. And I do have to say, in 10,000 Voices, in terms of developing the surveys, engaging with the public, we have had an immense amount of support from the staff on the ground. Parts of our groups, we have porters, we have the cleaners, we've got the domestics, we've got the receptionists, we've got the doctors, we've got the nurses, and we've got the social workers, all as part of the design groups. They're not just part of those design groups helping us with the surveys, but they're also part of the groups that analyse the information coming back in. And then we have those people, including our patients and our clients, as members of the improvement groups. So, for example, we have got an improvement group looking at the environment within EDs and what we need to do to try and improve the environments. For example, having quiet rooms and viewing rooms for people that perhaps have have died within EDs, and those improvements have been taken forward by actually the staff on the ground that are part of those design groups, along with patients and their carers. So it is ensuring that people are kept involved along the full pathway, including the parts that we take time out for service improvement, but we will in phase 2 go back in and review then our EDs again. We intend to do that, and we have our plans in place to do that.
Great. Thank you. My last question, and I won't provide. You might have been in the room when I spoke earlier with the RQIA, so I won't rehearse all that about human rights-based approach. But I'd be interested to know briefly whether or not human rights have an explicit place in the various programs and plans and strategies of the PHA.
Yeah, they have a very explicit role within the core corporate strategy of the PHA. I mean, we based it on Sir Michael Marmot's work within the World Health Organization, and I'm going to give you the titles which will be familiar to you. First of that, and this drives all our resource allocation as well, give every child the best start in life. And that was based on Article 3 of the UNCRC. Another one explicit for us is to ensure a healthy standard of living for all, which is based on Article 25 of the Declaration of Rights. And in relation generally to Article 12 elements of it, I mean, a lot of the work we do respect the views of the child, a lot of our involvement and engagement, and that rationale for direct involvement of children is in there. The explicit bit is an interesting one. I'll probably get into trouble with you in this one here. I actually think our legislation in relation to my responsibilities, which is very clearly to improve health and well-being, protect the health and well-being of people in Northern Ireland, and reduce inequalities, is actually a clearer statement than the conventions on human rights. Clearer. And I think all of us, what we jointly face is the operationalisation of that. And I did hear the question to RQIA, where I would suggest something that you might want to look at, which is happening across government at the moment. Local government are moving with their transformation in the RPA. We are all in the same language of outcome-based measurement, and it's on the same set of issues. And I think in there you might get a key that joins up the different parts of public sector, and will actually force all of us to rethink how we frame our targets into territory that I think will really be fitting well in terms of the human rights agenda, and allow a more explicit, because I have to say, while I pick the articles up, I have a little biasness here. I was part of the UK delegation to the UNCRC in Geneva at one stage, and was a quality director in Northern Ireland in my previous job coming here. But we don't sit down and do a matching. But I honestly believe that in terms of our work, particularly the Public Health Agency, our sectional legislation is so clearly within that framework, as are our internal targets. But as a way of progressing, I think certainly the work in terms of how we actually join up, what it will take us to, and I'll not go on about this too long, where it does take us into territory, it all takes us into the same challenge, and that is very quickly we move out of the health realm. When we start looking at the logic of these rights, and it takes us into the joined up government element of it. And I think that's why health sector struggles sometimes to put these into operational issues, because they can't deliver the whole of the operational line, because they're dependent on education and other people for it. But I think it's a good challenge for you there.
I just see such a profound complementarity between the sort of language and experience that you usually use.
Yes.
And the human rights language and experience. And I have a sense that there's a missed opportunity here of joining the two together and enhancing both as a consequence. But thank you very much for your time.
Thank you.
Marion, I know you wanted to come back on one issue, and then we'll close.
This is what happens when you don't use all your time talking to get another question. I'm just wondering, the local health and social care commissioning groups, do you think they have any role which would have an impact on reducing some of the pressures that go to emergency departments?
Okay, I mean, I think, we treat it as an integrated system, Marion, and all the parts of it, and the way the legislation is framed, it links them in. So my legislative responsibilities are exactly the same for local commissioning as well, and they fit in as well within their reporting line to the Health and Social Care Board. That local level is so important. And it's really where we get the connection into the community, because the bit if we're going to solve what happens in terms of the pressures that are happening within unscheduled care and A&Es. Ultimately, we've got to get to building the capacity in the community. And while for health and social services bodies generally, the emphasis is in terms of getting more and better community contact with the services, there's another layer out there in that world that the LCGs are very closely connected into, and that is actually building a caring community that is beyond the health and social care services. We really need to get to all of those levels if we're going to seriously tackle the long-term flow into the system. And that's a challenge for all of us, but it is a shared challenge.
Thank you very much. Thank you.
I have one very final quick question that just follows up something which Paul was asking. And I wondered, Pat, if you'd tell us that you said, and I understand entirely why, that you almost with 10,000 Voices need a pause to allow the learning to happen and then to commence again a kind of ongoing process. And I just wondered, do you have any sense of what you think is the ideal period for that pause to allow trusts to implement the learning and then to come back to the process?
Well, in relation to our emergency departments, we have paused for 6 months because we believe that we do need a 6-month cycle to allow for service improvements to become properly embedded into practice and to give staff some time out to become engaged in the process so that there's ownership. And that's really, really important. Okay, no, thank you. I'd just like to thank both of you for your evidence, extremely helpful. As we've said to all witnesses, we are happy to take written submissions. If you want to augment anything you've said today or anything additional that you think should be drawn to our attention, we will very happily take written submissions. And thank you for giving up your time this afternoon. That's been really very useful for us. Thank you.
Thank you.